Hi. Oh.
Yes, it stopped shaking.
No, good.
We're not having an earthquake, although
No.
we have had several recently.
Yeah.
We've been talking today about advance directives and about people making their wishes known and getting that stuff done legally so that they actually ensure that they get their wishes followed. What we're going to talk about now is we're going to talk about Polst.
Another document.
One more document, and this one's a bright pink document. And as I've said before, the document that I'm going to talk about today and use today is a document for California, but there are this form.
It's the Polst and
Post, and it's called different things, but usually it's a bright color. And the reason it's a bright color is so that it stands out in a paper chart. You can actually go right to it. You can see it.
And if you need be, you can have it with you and the paramedics will find it or the police will find it.
Yeah. And a lot of times whenever people complete these, I always tell them to put it on the outside of the refrigerator. Because everybody has a refrigerator, at least we think. And
or in the glove compartment of your car.
Yeah. But it's important for people to have completed this document who these things matter. Now,
yeah. In this case, ladies and gentlemen, it's really more for what Michael and I refer to as late stage, end stage patients.
Right. The other documents that we talked about could be done with anybody who is alive. You know, you don't have to be ill. It's important for you to, get your point across in terms of how you wish to be cared for if you can't speak for yourself. And so this document's going to do a little bit different for you. And as I've said, it's pink. And on the top of it, it says physician orders for life-sustaining treatment. And that's short for, that's why we call it a Polst, P-O-L-S-T. And the Polst document is a medical order. And so when this document is complete and signed by your physician or a nurse practitioner or a physician assistant, this document is a legal document that requires other physicians, regardless of whether they know the physician who signed it or not, it requires that they follow the orders that are on here.
Correct. And understand, when you show up in an ambulance or in your car to the ER, you're not going to have your physician who knows and understands you. You're going to have an emergency room doc who's going to turn you over to a hospitalist, and then whatever follows. Yeah. They have to follow this.
Yes, this document, when it was being created in the state of California, went through great efforts to protect physicians who are receiving you.
Yes.
That as long as a properly documented form that's been filled out appropriately, that has the name, phone number of the physician who completed this or nurse practitioner, then the physician in the emergency room can and will follow it.
Right.
Now, I want you to know something. I haven't told you what's in this document, but family members do something with this document sometimes that's not really helpful, is they tear it up.
Yeah.
And they figure, you know what? We're going to the hospital. We're going to have everything done. I don't want this document stopping them from providing care. Now, I don't want you to tear it up. I want you to show the emergency room physician or the staff in the emergency room that, you know what, this is what we've wished in the past, but we're here now, and the problem that we're dealing with, we don't think it covers what's being listed in this document, but we want some care. And so before you go and tearing this up, it's important for you to explain that you have had one of these before, and maybe it's just this is an opportunity to revisit it.
Correct.
What I want to do is I want to tell you that there's 3 sections to the document. The first section, it has to do primarily with CPR and cardiopulmonary resuscitation. Now, if a person has no pulse, is not breathing, that is when you get CPR. You have to be pulseless and breathless. Mm-hmm. It means you're dead.
Yeah.
You are dead. For all intents and purposes, you are not alive.
Yeah. Things
have stopped. Now, the choices at that stage are attempt resuscitation / CPR.
Attempt.
Yeah. Or do not attempt resuscitation, allow DNR. Now, Gail already jumped ahead of me here a little bit because the most important word in this section is the word attempt. Because a lot of times people think, if I want it, I will live. I want to live, so do CPR.
No.
Now that's another way of saying it. They will still attempt CPR. It doesn't guarantee that you will live.
Well, the problem, and depending on your age and your condition, is when they get going on you, they crush your ribs, they crush your sternum, they do all kinds of horrific things to the body to try to get you breathing again. I mean, I'm sure you've watched television and all the emergency stuff. It's true.
Yeah.
But they don't show you the damage.
No.
And all of a sudden somebody will say it's been too long and they walk away.
Right. Well, guess what? In
Yeah.
the emergency room, if you come in and you are they attempt resuscitation, they will place you on a ventilator.
Mm-hmm.
You will be, if your heart starts beating again, they will have you on a ventilator and you will go to ICU. Right. Now, there's a good chance that will happen, but there's also a good chance you'll never leave the ICU alive. So I think it's important for people to understand that the word attempt is used very specifically, because guess how many people, what's the percentage of people who survive and CPR on television?
Oh, everybody does. Or they show them die. If the character, it's important that they die, they let them.
I have the data. It's 76% of people survive CPR
on TV.
on television. 76%. It's a very high percentage.
But in reality, what is
in reality, it's a much smaller percentage.
And,
it's
maybe 1 out of 10.
It's so hard to make that decision, because a lot of the reasons why people don't survive is because they're dying from something serious, and that they're a very advanced age and they're just not going to survive.
They're not 4-year-olds who almost drown in a pool.
It's less than 1% of people over the age of 80, and someone who's much older. So what I want you to know, that if you make the decision to be a DNR does not mean do not treat. You still get care. You still get all the care that you would expect normally to receive, except if you go, except resuscitation. And in section B on the form is a little larger section, and it actually goes into a couple of scenarios that really talk about what kind of intensity of care in the medical interventions that you'd want. The first choice is full treatment. Now, I want you to know, you have to choose attempt resuscitation if you choose full treatment. You can't have full treatment and DNR. Yeah. Because full treatment means everything. It says here, the primary goal of prolonging life by all medically effective means. So in addition to treatment described in selective treatment and comfort-focused treatment, use intubation, advanced airway interventions, mechanical ventilation, and cardioversion as indicated. Now, you can ask for a trial period of full treatment. So what this does is it kind of gives your physician, the healthcare providers, an option that we're going to send you to the ICU, but it's the trial. And once you get there and they realize, oh, this was not a good idea, they can back off and they can actually do what we call a terminal extubation.
Yes.
Basically,
remove it,
turning things off and allowing you to breathe on your own if you can, provide comfort measures if necessary to make sure that you don't have a hard time going out. Yeah. But basically that's one way to have everything and have an exit strategy. The second area that you can look at and choose is selective treatment. The goal of treating medical conditions while avoiding burdensome measures. So you can say, I don't want to be on dialysis. I don't want to be on a ventilator. I don't want to have something that's going to be really complex and complicated. But I want people to do IV antibiotics. I want IV fluids. I want nobody to intubate me. I don't want them to put a tube down there, but I want them to do like BiPAP, where they put a mask on you and force cesarean, and you can have that as a trial as well.
Now, folks, this stuff is very complicated, and the average person has never experienced it. If you have been around for a family member who has, and they survived, 9 times out of 10, they will tell you that they would never do it again. And you get to see, if you are make yourself available, the process that the patient has to go through. So you can determine for yourself whether it would be right for you. And if you've had good discussions with the patient, then you can also make good decisions on their behalf, knowing them.
Yeah, absolutely. So the last part in this section is comfort-focused treatment with the primary goal of maximizing comfort. So this is hospice. This is making sure that you get adequate pain relief, making sure that if you're having a difficult time breathing, that you don't have a struggle, and that it makes you very much more comfortable, and that the focus on both selective treatment and comfort-focused treatment is to only request transfer to the hospital if care cannot be provided in the environment that you're in. And so almost all the time it can be, but if it has to be, you're not going to be left in suffering. And so that's the most important thing to take from Section B. Section C has to do with artificially administered nutrition or hydration. And so this is a feeding tube. Now, I want you to know they can start off with a feeding tube here. It's called a nasogastric tube, and they may do that at the beginning if you can't swallow. If you have a difficult time swallowing normally your food and fluids and things like that through your mouth, they can do that, and that can sustain you for a period of time. Now, most of the time, and this is something that they don't tell you, is that you can't have an NG tube long term.
No.
They really want it placed directly into your stomach. It's called a PEG, and it's percutaneous endoscopic
Very good.
gastrostomy tube.
Very good.
Anyhow,
Very good.
anyhow, it is artificially being fed, and it's. I used to tell people, that's the one thing that I don't want to have tube feeding, but you know what? Every morning I have a shake, and it's made by the same company that does the tube feeding. So I'm having tube feeding every morning before I go to work. But not to make light of it, but certainly sometimes people want to make sure that they express to their family members that, you know what, I don't want to be kept alive artificially in any way. The next section is where you list whether there's an advance directive and who that healthcare agent is. You can identify healthcare agent at this point. Your physician or nurse practitioner or PA can sign it. They need to sign it completely, filling in their phone number and their medical license number. Then you need to print your name, sign it, and put your mailing address and all that stuff. And it's just so that you know all of these things are, the copies of these documents are as good as the original. The only way that you know that it's no longer valid is if you have a new one that has a more current date than the old one. And so you can get rid of those old ones by just drawing a line through it, and most physicians will understand what you're meaning from that. On the back of the document is an area that says who helped you do this document. If someone helped you do this document, that person can put their name and address and phone number on this document as well. There's a section in here in terms of how healthcare providers should help with completing this. The completion of this document means that a rich conversation was held. Mm-hmm. Now, it's either she or I having this conversation, it's a physician having this conversation with you, identifying yourself as a person who's had this conversation, being willing to explain that to the physician who's going to sign this, and getting it signed, making copies, give this back to the patient or the family so that this always goes with them, so that whenever they come to the hospital, that it's scanned and put into the electronic records. So,
and if you use the same hospital, they will have it scanned.
Yeah. One of the things that I think is kind of nice is that this document says, yes, I want everything to be done. No, I don't want everything to be done. Or I'd like to try certain things. Mm-hmm. So it gives you lots of options that become a medical order that basically travels with you wherever you go.
And the more medical you have had in your life, the more critical it becomes and the more understanding you have of how important that is. If you're a newbie to this situation, this problem, you're going to probably select, do everything for me. But if you've been around the block a couple of times, you're going to be far more aware.
The other, and I'll just, as a last point I'll make, the other point that I want to make sure that people understand is that this document is primarily done with people who, if you're the physician completing it, you would not be surprised if this person died within a year to 18 months.
Correct.
So if you would not be surprised that you heard that they died in that period of time, then this is the right document to complete.
Yes.
If they're going to be around for a while, make sure that they look at the 5 wishes,
others,
the other documents.
And yes.
This can be completed for anybody, but it makes more sense with people who are at the end of their life.
Yeah. What I refer to, Michael and I, medically late stage, end stage.